Good afternoon. Thank you for coming. This is our 10th week of the quarter, so I particularly appreciate that we have a good turnout for this seminar series in public health. This quarter has been probably one of our busiest and most distinguished so far. We had seminar series every week, and I'm delighted to support the program. I'm Dele Ucheto, I'm the chair of the public health department here at UC Irvine, and we always appreciate the support of the Office of Extension, University Extension, to help us record this seminar series so that it even reaches beyond the halls of UC Irvine, and people can watch and question and learn about the topics worldwide. This series is not just the coming out of the mind of one person or two or three. We plan them sometimes a year in advance, and we rely on the network of our faculty and the network of our students who have known excellent researchers, administrators, public health practitioners in their own work. So we take nominations, we vet them, and we schedule them. And we depend on the audience that we pull from our public health program, graduate, undergraduate program, faculty, and campus-wide. And occasionally we get members of the UC Irvine community outside of the university to attend. And this is just one of those distinguished speakers that we have today came to us because of the network that has been built by one of our affiliated faculty members. So I will introduce Professor Bejat Sharif, who has an appointment as a professor at Cal State Los Angeles in the Department of Public Health there. And she came to us now more than about a year ago that we've been having discussions about collaborations between her department in LA and our program in public health here. And I'm extremely delighted that last quarter we began the first phase of that collaboration by having her introduce a course that I'm sure some of you have benefited from, or maybe even now. She's an expert in health promotion issues, and we look forward to continuing to collaborate with her and that she can interact with our students and faculty over the next years. So if you don't know her, this is a good chance to put the face to the name. And she nominated our distinguished speaker for today, Professor Don Moresky. So please join me to welcome Professor Bejat Sharif, who will then introduce Professor Moresky. Thank you.
Thank you. Thank you very much. I am delighted to have this opportunity to introduce Professor Moresky. It is beyond the capacity of time and possibility of the page limitation to introduce the breadth and depth of the expertise of Professor Moresky to be given a brief overview of his background. I have some information to share with you, and I will go ahead and read the information. I ask Professor Moresky to fill in any information that is necessary for you to know. Dr. Moresky is a professor in the Department of Community Health Sciences at the UCLA School of Public Health. Prior to his arrival at UCLA in 1982, he was on the faculty of the Johns Hopkins School of Public Health, where he received his Doctorate of Science in Health Education and Health Behavior. His research program includes planning and evaluation of patient and community-based health education programs, international health, adherence to medical recommendations, STI, HIV, AIDS prevention, hypertension, diabetes, and tuberculosis control, particularly among adolescents and adults population. As a professor, Dr. Moreski teaches the department core courses in program planning, survey research, methods and evaluation. He also teaches courses on research methodology and courses addressing the social and behavioral determinants of HIV/AIDS prevention, particularly with a global perspective. He is a member of UCLA's Asia Institute. In addition to English, he is fluent in Spanish, German, Japanese, and a number of Filipino dialects. I appreciate the comments of Professor Odin Seiden, and I would request you to give a very warm welcome to our distinguished speaker today, Professor Moreski.
Thank you very much, Bejat, for that very wonderful, warm introduction. My father would be proud and my mother would certainly believe it. I'm really very happy to be able to meet with you and to go over the research that I have been very much involved in the last 15 to 20 years, particularly in the area of HIV/AIDS prevention. I thank Dr. Devi to invite me here and participate in this very informative research seminar. My background in international health really began when I was a Peace Corps volunteer. After I graduated from the University of Arizona with a degree in chemistry and physics, I joined the Peace Corps and was assigned in the Philippines. I was going to be assigned in Korea, but they pushed me harder to get into the Philippines. It's sort of like a government type of opportunity in which there are a lot of unknowns. So I was trained in Ilocano, which is spoken in the north, and when I arrived in the Philippines, I was assigned in the south, in the Bicol region. So you learn two dialects, and then I learned Tagalog, the native language or the national language that is spoken mainly in the Philippines in Manila, in the greater Manila area. Outside of the greater Manila area, the dialects is the predominant means of communication. However, English is the second language, and it is integrated into the grade school at grade 2. So it's a transitional period, and all through the entire curriculum, they speak English. They have English textbooks. So English is a widely spoken language. So it's not too difficult to get by in just English, but if you really want to get involved in the culture, you have to know the language, and you have to know the nuances of the language. So that's really appealed to me. I was involved in HIV/AIDS prevention research in Los Angeles County in 1985-86, and we had a CDC prevention funded research program in which we were looking at the risk-taking behaviors among patrons of the bathhouses in Los Angeles County. After the AIDS epidemic started in 1982 in California, all of the bathhouses in San Francisco were closed. But in Los Angeles, because of the relationship that the owners and managers had with the Board of Supervisors of LA, they were able to keep them open, provided that they responded to some of the findings that we found in our needs assessment, which were some high-risk taking behavior activities and recommendations in terms of educational materials and provisions of condoms and things like that in the bathhouses. And until today, the bathhouses are still open. Dr. Deedles, my very esteemed mentor at UCLA, who was the dean of the School of Public Health when he interviewed me in 1982, and I was offered the tenure track appointment at UCLA, was the principal investigator of a Fogarty, a National Fogarty, which is the International Training Center of the National Institute of Health, training grant. And his training grant was particularly directed towards the epidemiology of AIDS. So he identified 6 to 8 countries in Asia and in Brazil, one country in South America, and went to the Minister of Health or to the top academicians in the national universities and presented to them a series of courses that they could have a one-week workshop. The natural history of HIV, the immunology, the virology, and rapid survey techniques. All of these administrators were very interested in the epidemiology, but they said, there is no cure for HIV. We need some kind of behavioral intervention, behavioral research approaches that look at the risk-taking behavior and how we can prevent that from occurring. So, because Dr. Ditos was aware of my work in HIV, he invited me to join his research team, and I put together a one-week training program for HIV/AIDS in a number of countries, particularly the Philippines, Indonesia, Thailand, and Singapore and Brazil. Today, Dr. Ditos is working in China, India, and Vietnam, as well as these other countries. And in working with these participants in this training program, I began to see an interest in research, not just the training, but the actual research. And so my colleagues at the University of the Philippines College of Public Health fortunately had trained many of these physicians and nurses in their MPH program at the University of the Philippines. And so they could identify individuals that would make great co-investigators in an NIH-funded research program. And fortunately, we put together a 5-year program targeting the high-risk female bar workers. Mr. Salas here can tell you about the bar workers in the Philippines. They go by a euphemism called GROs. And what is a GRO?
A guest relations officer?
A guest relations officer. A very high status name, but they are receptionists or hospitality girls, and they serve the customers, the clients, in bars and restaurants and beer houses and karaoke centers. They're not all sexually active, so we don't call them commercial sex workers because that is too stigmatic. But you have to be very sensitive to the culture in the Philippines. So we call them GROs, or we call them female bar workers. About maybe 60% of them are actually sexually active. So in this research program, we put together a 5-year program for HIV/AIDS targeting the female bar worker. And then at the conclusion, sort of at the 3rd or 4th year of our program, we began to look at, well, what's the next area that we're going to address? And my co-investigator said, we have to look at the other side of the equation, and that is the potential client-centered populations of the female bar workers. So fortunately, in our needs assessment, at each of our pre-test, post-test, and follow-up phases of our intervention, we collected data regarding who are your usual customers. And military, police, factory workers, transportation drivers, the pedicab and the taxi cab, and communities that reside, or men from the communities that reside near the various establishments that we work in. So with that background, let me give you an overview of the title of our program was Behavioral Interventions in Support of HIV/AIDS Prevention. So this is really intervention-based. It starts out with a needs assessment, working at the situational analysis in the community, excuse me, working with our counterparts. It's very, very important in community health planning is that you actively involve your counterparts and make them the decision makers. We are the external resources. We provide them with the information, but they are the ones involved in the decision making and the integration of successful components of our program into the usual healthcare delivery system. So our counterparts include the city health officers, the regional health officers, and the rural health officers. They also include the managers and the owners of the commercial sex establishments, or the bars, the nightclubs, the beer gardens, the saunas, and the karaoke TV centers. So that is what our population consists of. And we work very, very closely with these individuals. Monthly meetings. Our staff in the Philippines consisted of a principal and co-principal investigator. The day-to-day management was directed by the research manager, and also we had site coordinators in each of our 4 sites. The coordinators met with the managers, and also the other group that we worked with were the female bar workers, and we trained peer educators. I will walk you through each of those steps. And collecting the data was also done by independent investigators or researchers from the University of the Philippines or the Ateneo de Manila Institute, their nursing school. These were generally nurses that resided in the provinces where we worked and conducted the interview in the native language. We worked with 3 major languages, Tagalog, Bicol, and Cebuano. So this program was funded by the National Institute of Allergy and Infectious Diseases. Perhaps you heard of that division. They sponsor most of the research, and the director of that is Tony Fauci. And Tony Fauci has been in the news in this last couple of weeks. Anybody know about the recent news of HIV prevention or HIV cure? A young baby? Yes. It's one of the very first times that we see, well, the second time that we see that maybe prevention or cure of HIV is possible. The secret is what? Early intervention, right. Let's see it. Can I just click that? Okay, here. Oh, and this will actually click it too? Excellent. Okay, so the pointer is, let's see. So how do I get the pointer to go on like this? Oh, there it is. Okay. So some background here in terms of the magnitude, the significance of the problem. So daily, this is daily, 16,000 new HIV infections occurred in 2011. In 1 year, there's over 4 million new HIV cases in the world, 3.5 to 4 million. More than 95% are in the developing country, predominantly where? Sub-Saharan Africa, where we have about 2/3 of the total world population. About 14,000 of the 16,000 new cases are in persons between the ages of 15 to 49. However, we're seeing an increase in the average age of infection, going up to not only 22, but now already up to about 32 years of age for the average age of infection, of whom over 50% are women. The epidemic in women is predominantly heterosexual. In the United States, it's a combination of men who have sex with men, injecting drug users, and heterosexual. In the developing region, in sub-Saharan Africa, 97% is heterosexual. Very little MSMs and almost 0 injecting drug uses. Female sex workers or female bar workers are at a high-risk population for contracting HIV. And the main reason for women that are coming into this high-risk population or this high-risk group is the issue of poverty, cultural and linguistic diversity, level of migration, rates of economic expansion, and the status of women. Tim Brown from the East-West Center said that back in '94, and it's still correct today. Commercial sex work related activity has been transitioning outside the brothels as legal pressures escalate and as customers perceive this type of pressure. So in certain countries, like in Thailand, the female bar workers are really the largest group of individuals are working in brothels. And brothels are very, very different type of, it's where the sex takes place. In the Philippines, the female bar workers are working in establishments. And one thing about the Philippines is that back after World War II, the government required that the owners have all of their employees registered in the social hygiene clinic. They must also undergo weekly or bi-weekly clinical examinations. If they are found to be STI or sexually transmitted disease infected, they have to purchase a prescription on their own. There's only about 5 countries in the world, Senegal, Costa Rica, South Korea, maybe Netherlands, that have these types of regulations. In our own United States, we have brothels like in Nevada, and Nevada is under the city government in their localities, and all of their sex workers are registered and undergo monthly examinations. In Nevada, there have been very, very few, if any, HIV cases. So you can see the tremendous opportunity for organizational policy or educational policy in the organization, which require individuals to be registered and undergo regular examinations. Also, in our project here, we're looking also at organizational policy in terms of the interpersonal communication between the manager of the establishment and their employees. And so this last thing here is that as legal pressures escalate on the brothels, because brothels are illegal, even in Thailand, but they disguise them as massage parlors. In the Philippines, there are very, very few brothels. They call them casas, and they're only identified by maybe taxi drivers. Our interventions were targeted to the establishments. Why would we go to the establishments? Because there you have control and access to the high-risk population. Although we did involve what they call freelance workers, which are female sex workers on the streets, that was because of the need, but they were not part of our regular intervention population. They were able to get into the social hygiene clinic and receive access to the examinations. So the sex industry is economic hardship drives the women to sex work. The link between economic hardship and sexual practices has been widely discussed, and governmental regulations, as I mentioned. When we started our work in the Philippines, we had no idea of what the prevalence of HIV/AIDS was. We could look at previous assessments by organizations such as the World Health Organization and the UN AIDS program with regard to the prevalence of STIs, or sexually transmitted diseases, in the Philippines. And so that was one of our measures that we could rely on. However, it was only a surrogate of HIV. The United Nations, the UN AIDS program, identified, when we started our program in the Philippines, that there were 50,000 HIV persons living with HIV. However, every year they lowered that number. And it wasn't until Sentinel surveillance that started in 1997 actually recorded the prevalence by assessing a Sentinel population in 12 regions. Sentinel populations in 12 regions. And a Sentinel survey identifies a minimum of 400 high-risk individuals: female bar workers, high class and low class, MSMs, injecting drug users, etc., the high-risk group. In certain regions, they could not even find 400 injecting drug users. Drug use is not common. Injecting drug use is not common in the Philippines. In Thailand, it is very, very common. Injecting drug users are a double risk group. Not only are they acquiring and transmitting HIV through their injecting drug behavior, but they're also infecting men and women with regard to sexual activity. So, although the Philippines, when we started, we saw that does not really have the magnitude of HIV as other countries, it does not allow us to sit on our laurels and say that there is no problem. We can learn an awful lot from why the HIV prevalence is low in the Philippines and begin to institutionalize some of these reasons in terms of policy. So longitudinal determinants in terms of our objectives have not been done much among sex workers in the Philippines. Also, this provided us with an opportunity for a joint collaboration with faculty from the UCLA School of Public Health and the University of the Philippines College of Public Health to begin to do a 4-group design in the Philippines. Also to assess the independent and the combined effects. So when you look at the independent, you're looking at main effects. When you're looking at the combined effects, you're looking at interaction effects. And I'll show you the different main and interaction effects we're looking at with regard to female bar workers. Educational interventions targeting cognitive and environmental determinants of STV are then being assessed. So we're looking at 2 levels here. We're looking at the educational interventions targeting the cognitive, so the knowledge, the attitudes, the belief, the values, their self-efficacy, their communication skills. All of these are linked to cognitions, becoming skilled and aware. The environmental determinants here are looking at what we call socio-structural determinants. And social structural determinants are the value-added effects of an intervention. They remain part of the capacity of the organization. So as you as a researcher begin to step back in terms of your implementation and evaluation, you're giving more, you're empowering your collaborating partners to continue and to develop and implement over time. So our objectives were to look at the cognitive aspects of our intervention and establish baseline prevalence rates. So we could go to each of the clinics in our 4 community sites and access the clinic records over a 6-month retrospective period to establish a baseline measure of sexually transmitted diseases. This is one of the few studies that actually has been able to collect on a longitudinal cohort over time. And so it's not self-reported. So we can also ask self-reports and correlate those measures with our hard empirical data. It also allows us to look at the effects of educational strategies. Whoops. Let's see. Oh yeah, it also allows us to look at the educational strategies directed towards the managerial reinforcements. So that is one of our interventions, targeting the manager. Why the manager? Because before our program, we did a lot of observation, and we could see that the manager has a critical role in terms of the enforcement of policy in the establishment, based on their knowledge, attitudes, beliefs, and practices. And they were also trainable in terms of looking at establishment of social norms in the establishment. We observed also that female bar workers that were negotiating sexual activities generally did not occur in the establishment itself. It occurred outside the establishment, where the female bar worker loses any empowering communication. So we made sure that the female bar workers were trained to discuss the type of sex, the use of condoms, and payments in the bar before they leave. And before, the manager would generally pit the female bar worker against the client in terms of siding with the client, saying, he's a friend of mine, he's going to treat you well, and to follow his lead. Well, that was changed as part of our intervention to make the manager responsible and reinforcing the importance of knowing your partner and using consistent condom use. And so that was one particular aspect of it, was the manager. The second was the issue of peer counseling. And so in each of our establishments that were assigned, that were randomly assigned to the or the community that was randomly assigned to the peer education program, we had at least two, and multiples of two depending on the size of that establishment. So beer gardens had maybe 8 to 10 employees, and karaoke TV centers had around 80 80 to 85 employees. So you could see that Karaoke TV's had a higher number of peer counselors. Peer counselors and the managers were trained for 5 days with 2 days of skill building and interaction between peers with regard to role playing. Bandura's social learning theory was used in terms of communication skills and self-efficacy. And then we had the combination of these two and comparing to a usual care group. And then to expand the current STI program, we used a participatory action approach, participatory action research approach that targeted the male-centered populations. So the educational program, based on the theoretical, as we mentioned, cognitive, social structure, and environmental targeted factors targeting the CSWs, communication skills, empowerment, self-efficacy, and self-esteem, and the manager owners of the establishment. So those were our target groups and the content areas of our intervention program. This is an overview of what our overall, what happened? And maybe it went back. Let's see, have to press the top one. So we're looking over here in our dependent variable, which is health protection behavior, really looking at consistent condom use and high-risk sexual behaviors. Outcomes look at STIs or STDs and HIV. STIs are collected on every clinic visit, so we can assess the at-risk behavior of each of our female bar workers in the establishment each month by the site coordinator assessing how long have they been actively working in that establishment. 1 week, 2 weeks, 3 weeks, or all 4 weeks. So that is our denominator, and the numerator is the denominator is the potential number of weeks, and the numerator is the actual number of weeks. So if they're all 4 weeks, well then they get 1. If they're there, but they didn't have an appointment, well then they would, any of those weeks it would be 0. So that's a dichotomous variable. HIV status, every 6 months, all female bar workers and employees of the organization have to have a blood test at the city hospital. And so that is another source, but that is at the aggregate level. It's not at the individual level. The SCIs are collected confidentially at the individual level and analyzed at the aggregate level. Communication skills is a mediating factor in negotiating skills. In terms of our independent variable, we compared it to a standard care that is ongoing, which includes the clinic nurse giving instructions to all female bar workers. And our intervention included the standard care plus peer educators looking at social influence and manager training, and this important area of a structural intervention called organizational change behavior, organizational policy. We have 4 groups here that we're looking at in terms of our quasi-experimental design, and our target population are the entertaining workers. And these are factors mediating the dependent variable. We have the socio-demographic factors of age, education, et cetera, the situational factors in terms of self-esteem and self-efficacy. The social support and sexual communication are very important among the peer educators and their manager. Social structural factors include the availability and the accessibility of HIV prevention education materials, the availability of condoms, and the all-important organizational reinforcement of those behaviors over time. And then we have your cognitive factors, and these come out of the health belief model in terms of perceptions of beliefs about the benefits of condom use, the severity of the HIV in terms of becoming infected and how that's going to affect your employment, your economic situation, your family structure, et cetera. And then looking at AIDS concerns and knowledge attitudes. The socio-cultural factors are interesting that look at the perceived cultural norms regarding behavior, the cultural values regarding gender norms during sex, peer and employer support for negotiating behavior, so the all-important role of the manager, fatalism, mutual obligations, machismo and mariamismo, sexual taboos, and cultural views of illness. all very important social cultural factors. So in our baseline, we identified approximately 14,000 commercial sex workers or female bar workers, over 250 establishments in 4 areas of the southern Philippines. And this is the outcome measures, as I mentioned, include these activities. This is our quasi-experimental design. So it's impossible to randomly assign individuals in each community to one of these 4 groups. So you use a quasi-experimental design in terms of making sure that your cities are comparable to each other, that one city does not have a higher educational attainment or a higher socioeconomic status, that there are social cultural centers, social hygiene centers in each of the cities. There's approximately equal number of establishments in the cities and the types of establishments. There's a city health officer that provides a social hygiene clinic. So all of those are commonalities that you have to identify. It strengthens your design. In fact, it's very close to a pure experimental control design if you can match everything and rule out any kind of threat to internal validity. So we have a randomized design and we have the assignments. All of the 4 areas are put in a hat and they selected with replacement 1, 2, 3, and 4. And these were the assignments that took place. In terms of the archipelago of the Philippines, we had 4 sites, one in Legazpi City, and then the combined site of Cebu, which is 2 cities of Lapu-Lapu City and Mandaue City. We have a 3rd site here of Cagayan de Oro, which is in the largest island in Mindanao. And then we have a control city over here of Iloilo. So all of these are non-contiguous. So all of the interventions are unique to that city. There is no sampling in this study. It is a true population-based survey in which we identified all of the commercial sex establishments, and we had over a 95% willingness to participate. So there are very few threats to validity in terms of selection. These are some of the scales that we identified in terms of very, very important predictors of HIV prevention. And the behavior that we're looking at is consistent condom use. So we look at manager attitudes, which were assessed by asking the manager their specific attitudes towards condom use or to HIV/AIDS. We have the perceived manager attitudes, in which we ask the female bar worker what they perceive their manager's attitudes to be. We look at self-esteem, and that is Rosenberg's self-esteem scale. And these are Cronbach's internal consistency reliabilities in terms of the standardized alpha. We look at AIDS education, which is their level of knowledge. We look at negative attitudes towards condoms, and we look at consistent condom use and use. Consistent condom use, which is efficacy and use. So this is what our needs assessment consisted of. So when you begin an intervention, you certainly preface that with a lot of observation. You sit in the organizational establishments and watch the flow, watch what people do. Look at teachable moments, look at interaction, look at missed opportunities. They're all very important ingredients in terms of building a successful and implementing your program. You look at the STD rates in order to establish a baseline. You do exit interviews with female bar workers that were found to have an STD, asking them, what did the nurse tell you? What kinds of skills did you learn in terms of condom use? Focus group discussions were also very important, in which you begin to assess their knowledge, attitudes, the commonality between certain individuals, different levels of education within each type of establishment. You also test your educational materials and your questionnaire. It's a very important opportunity to test your interviewing skills and your understanding the questions that are part of your assessment instrument. And you have focus group discussions with both the manager and the female bar workers. And then you conduct interviews. And so we did interviews of all of the individuals that participated in our program at baseline, at pre-test, at post-test, and at follow-up. And that's with the CSWs and the managers. First, you're looking at some of the bivariate kinds of analyses that we did to look at relationships. So these are baseline assessments to look at the importance of whether or not a rule. So do you think a rule is important in terms of, and this is condom use during the last sexual encounter? You see that 75% of individuals that have a rule said they use condoms at their last encounter, compared to about 41% that there is no rule. So definitely that is a very, very important maybe environmental constraint. Yes?
What was the consequence of the rule, of breaking the rule?
Consequence of breaking the rule? That is a very difficult question because you're asking the manager to enforce it. Okay. If they break the rule, they are higher at risk of an STI. Okay. If they are found to have an STI, they cannot work until they are cleared by the social hygiene physician. That is a loss of revenue for the manager as well as the individual. So it is in their best interest to adhere to the rule, if there is a rule. Right. Now, we cannot force them to have a rule, but we can see that it's in their best interest if they do.
Yeah, and I was just wondering about the self-report of if there's a rule and they knowingly said they broke the rule.
Exactly.
Even if they don't catch a disease,
and so, Dr. Debbie, you raise a very important issue that we call social desirability. Okay, and I'll address that because whenever you ask a sensitive question, you have to be aware of the potential social desirability of your respondent. Now, we as psychologists can rule this out by asking them a survey or a scale on social desirability. What would you do with that scale? I will show you what you do with it to rule it out. Here we look at whether or not the CSW should have sex without a condom if a customer offers her more money. It's a very, very important decision-making opportunity for the female bar worker. They have children. Most of these have, about 40% of them have children, female bar workers. Maybe about 20% are actually married. And so they have economic burdens. So that is an incentive if they get more money. However, we have to emphasize the value of health. And that is the first level of concern in the health belief model. It's a value expectancy. What is the value? Health is the value. And what is the expectancy? It is that if you have a high level of health, well then you're going to have a high level of belief in the benefits of treatment, and the belief in the severity, and the belief in the susceptibility. 3 dimensions of the health belief model. Cues to action is another dimension. So carrying along a condom is also a very important, or having it available. So looking here in terms of the CSW, you see very interesting results. This is the manager in front, and behind is the female bar worker. Look at the female bar worker. They very high disagree, but the manager is somewhat neutral. So we can see that it is really, really important to get the manager on our side. Let's look at health. Here, the bar manager should be responsible for the worker. Hooray, we see 2 levels of very high levels of agreement. So we have our foot in the door in terms of making some headway with the manager, and begin to identify his or her responsibility in terms of counseling, educating, and reinforcing safe sexual behaviors among their employees. Next, we look at some odds ratios in terms of social influence. Okay, are condoms available at your establishment for the worker who works there? We see almost 3 times the odds of using condoms, ever using condoms, and a very high level of probability if there is a rule if they're available. If the establishment has a rule, again, 2.5 times the odds, 2.5 times greater than an establishment that does not have a rule. And has anyone ever taught you, and this is an important skill, a very important skill, that someone has taken the opportunity to teach them, either a peer worker or a nurse in the clinic, taught you how to use a condom properly, and we see, again, over 2 times the probability. If we look at odds ratio in terms of condoms that last sex, we see if they're available, almost 4 times the availability for last sex. And condom establishment work, almost 3 times the probability. So you see very high odds ratios with regard to having rules and available. This is the social desirability. So this is a graph of our social desirability and consistent condom use. Do you see a relationship between social desirability and condom use? Is the higher, you would hypothesize if you thought that there was a social desirability bias, those that had a high level of social desirability would also have a high level of, this is condom use, consistency of condom use over here. Do you see a relationship? It's pretty flat. It's pretty flat. In fact, it even goes down in terms of the proportion of individuals that have high social desirability that respond that they have used condoms during their last sexual encounter. So this gives us the confidence or the assurance that there is not a social desirability bias. They are not trying to please the investigator and saying yes. We try to address that same type of behavior when we're assessing medication taking behavior. If your doctor asks you, did you take your medicine yesterday? But most, probably 95% of people would say yes. Or do you ever have problems remembering to take your medication? See, that's the opposite. That's the opposite way that a researcher would ask that same question, and the no. So a no is a positive, is a high adherence response. So you avoid the yay bias by reversing your question. Do you have problems remembering? Do you ever forget to take your medication? When you're away from home, do you remember to bring along your medication? Those are very, very important approaches to assessing that kind of behavior. These are some of our pre-test, post-test outcomes with regard to, this is the very basic level of knowledge. So we look at differences in knowledge. So we have 62% versus 57%, and out of 1,394 individuals, we see that that was also positive in terms of a difference between intervention group and control group. When we ask them questions about their knowledge, these are the kinds of questions that we ask them. And it's interesting that we still look at causal or casual transmission by HIV, and it still is predominant in the less developed countries. But when you ask them, have you done anything to lower your chances, we see that the intervention group has done consistently higher levels of things at each of the pre-test, the post-test. Well, not at the pre-test, the control group is higher, but at post-test and at follow-up, you see big differences between the intervention group. When you ask them, what have you done, you see that the control group is identifying things that are less likely or less effective in terms of taking medication, 17% versus 3%, less sexual contact, no outings, a higher proportion of intervention groups, douching after sexual intercourse, higher proportion of control groups. So that requires high level of knowledge and understanding in terms of your interventions. So definitely you're going to have to try to address these misunderstandings and misclarifications. These are differences in terms of always using condoms. So this is our measure on consistent condom use. You see big differences from our control group at each of these levels, at pre-test, not at pre-test, but at post-test and at follow-up in terms of consistent condom use. The baseline significance was not significant, but post-test interventions or significance were consistent. This is the establishment has a rule. So at baseline, we see an average of about 38% of the well, see at baseline we have about maybe 50%, and then at post-test, for our intervention groups, we went to 40%, 60%, and 66%, whereas the control group actually declined over the three-year period. These are some of the issues of the variability of STIs by the types of establishments. So all establishments are not the same. We see that restaurants and which we do not have control over, but these are women that are participating in our program in terms of coming to the social hygiene clinic. However, because they are not establishment-based, or there's not enough individuals in these restaurants or casa brothel places, that we do not involve them in our intervention. But we do follow them in looking at the condom use consistently, less than 1% in restaurants and 4%. But in other places you see differentials, highest in the karaoke bar. This is highly correlated with education. Most of the female bar workers in the karaoke are college graduates. This is our condom use behavior scale, which has an internal consistency reliability of 0.82. And so you can see here, these are the ways that we measure this very difficult behavior. If a customer does not bring along a condom, how often do you ask them to? So that is the behavior of asking him. How often do you use a condom when you have vaginal sex? And these are from, never, these are from never, all the way up to always. Okay, this is the correlation, a very important correlation. So you want to see how well does your self-measure relate to consistent condom use. So if it is here inversely proportional, so the higher the condom use, the less likely you're going to have a STI. So this is the higher the condom use always, you see very different measures of proportion having an STI over the last 3 months. And this is a very complex design. This uses structural equation analysis, but it allows you to look at the explained variance and the unexplained variance of these different latent variables here. These are all latent variables here in terms of these are scales, or they're indices like knowledge, and these are based on a Likert scale. Here you see that manager attitudes. It has a very high relationship with condom use effectiveness, and it's a positive. So the higher the manager's attitude, the higher the condom efficacy and use. If individuals have negative attitudes towards condoms, they're less likely to use condoms effectively and use. If individuals have high level of knowledge, a positive relationship here. If their perceived attitudes are high, they're less likely to have negative attitudes towards condoms. So this is how you interpret this type of a path analytical measure on condom use effectiveness. Here we have our pre, post, and follow-up measures of STIs. This is looking at appointment keeping, and I mentioned how we measure appointment keeping. It's a very, very important measure, because if the individuals are not availing of the appointment, number one, they're not being able to identify whether or not they have an STI, and second, they miss the opportunity of educational counseling by the nurse. So at baseline, we see that pre-test, post-test, and follow-up. At pre-test, there's really no difference between the intervention group and the control group. In fact, there's a higher proportion of appointment keeping. But again, you see increases and a little bit of recidivism here, but you see definitely decreases on the control group. And so this was positive in terms of control group, but the intervention group had significantly higher probabilities of appointment keeping. So next you'd be looking at STIs. How does STI vary by our intervention groups? And that is by our peer counselors. You see at baseline it was 54%, and this is the number of STIs per 1,000 clinic visits. And so they had, say, 54, which is 5.4 per 100, or 4.7 post-test, and a difference of 6.9. So all intervention groups made a decline in terms of condom use in terms of STIs. However, the one group that was very, very significant and marginally significant was the manager, but definitely the interaction effects of the combination of peer educator and manager training had an overall 21.8% reduction in STIs. This is our data from the HIV test, and you can see that over the 8 years that we collected that data, from 95 to 6 years, we see that there were no STIs in our peer education group, 2 of them in the manager training, 2 in the combined, and 13 in the usual care group. A very significant difference in terms of HIV test. So this is how we conceptualize educational policy. So when you start with an intervention that tries to integrate the successful components of your intervention into the usual care practice of the organization, you start with the familiar. And so the first familiar aspect is that they meet regularly with their employees. Now, when you ask the manager, what do you talk about? Do you think they talk about hygiene? No, they talk about fiduciary issues, financing, the number of bar drinks, the number of appetizers, the types of drinks that the customer will buy. So all of that is income generating. What we work with in terms of our interventions is to discuss more about the issue of social hygiene, keeping your regular appointments, consistent condom use, the availability of condoms both at the organization and at the social hygiene clinic. Encouraging the individuals to attend the social hygiene is also part of that reinforcement. The positive behaviors in terms of, yes, I see that your clinic examination record has no report of STIs over the last month, and I'm very proud of you, and keep it up, keep up the good work. Providing insurance. This is a very interesting finding that we had sort of midstream in our implementation. We identified about 5% of our female bar workers had recurring infections, the same STI infection. They would be positive at one time, they would be treated, and about 3 weeks later, they would be positive again. So we conducted focus groups with them, and we found out that they were not using either condoms correctly, or that they were not purchasing the entire regimen of the antibiotic medication. Why? Because the cost of an antibiotic full prescription is about 2 to 3 days of full-time work. So it's very expensive. So they would only take 1 dose, and it would remove the symptoms, but it would not remove the overall infection. And then they would have to go back and get tested again. They would be infected again. So the managers actually put together an insurance fund, and that insurance fund would be available to the workers, and they could borrow from it. Of course, they had to pay a rate of interest, but it was a win-win situation in which they could purchase the entire regimen. They would not be removed from work because they had an STI infection, and the manager would gain in terms of economic revenue stream from their working employees. Providing AIDS education, attending the advisory committee meetings, and these are ongoing monthly meetings that the managers and the peer educators would engage in over the 3-year intervention period. Promoting AIDS awareness in the establishments by contests that the female bar workers or the peer educators would be actually putting together posters and flyers and educational messages in their establishment. And then providing educational materials to the customer, making condoms available to their female bar workers or to the customers. And the last, in terms of policy, mandating 100% condom use among their employees. So the results, you can see that our structural equation has identified significant predictors of condom use and efficacy. Pre and post surveys indicate changes in knowledge, attitudes, and levels of self-efficacy among the CSWs and the managers. The most significant finding is the influence of the manager supervisor on the knowledge and the sexual practices of the employees. The importance of integrating the educational policies for HIV is supported by the findings that the CSWs were twice as likely to use condoms if there was a rule in their establishment. So these are the conclusions in terms of that. And these results are being integrated into the social hygiene clinic, and we are doing now an expanded version in Manila, working with 2 social hygiene clinics there. So the importance of large-scale quasi-experimental designs, the rationale, the community-based participatory research incorporating successful components, and health policy implications regarding social hygiene are all recommendations that we have for our social hygiene clinics. These are things that we saw here, and so integrating these into the establishment, managers meet regularly with the guest relation officers to discuss social hygiene. Managers assure the support of safe sexual practices, and 85% of the establishments now have a policy regarding consistent condom use. So you might wonder, why is the Philippines such a low prevalence for HIV? Some of the epidemiological information that we collect is that there's a low viral pool, which means that there is not a concentration of HIV in any particular geographical area. And if there is, that geographical area is generally separated contiguously in terms of the archipelago of islands, the vast number of islands, that it's very difficult to get from one island to another. It's not like India or Thailand that you can take a train and get from one region to another region. The Sentinel surveillance also identified, as I mentioned, in 1997, where they actually identified the total number of people, of the proportion of individuals. So if you identify a minimum of 400 individuals, you can have the probability, the accuracy of assessing less than 1% or in increments of greater than or equal to 1%. The other one is the low number of sex partners. In the Philippines, from our data, we see that the Philippine female bar worker has an average number of sexual contacts with their clients about 2.5 times per week. That compares to Thailand that has 4 per day. Very, very different. The HIV/AIDS epidemic in the Philippines currently is about 10,000. 10,000. So it went from 50,000 back in 1995 when we started down to 10,000 as the actual rate. In Thailand, it's over 1 million. The population of the Philippines is about 90 million, and Thailand is about 60 million. So very different disease. And the predominant influence in Thailand is the bridge population. The bridge population is the injecting drug user. If you look here at low rates of IDUs, of injectable drug use among the female bar workers in the Philippines is another reason. All of the workers are registered, and that does provide a very important opportunity for counseling. And integrating, of course, what we think is hopefully happening over time is the integration of this into the social policy. Let's see, I better hurry a little bit here. Okay, this is the expansion, and so this is the other side of the equation. I'll go through it very quickly. This design here is not a it's a sort of a quasi-experimental design, but it's a crossover design. So this is that we observe all of these high-risk populations at time 1, and then in half of them we have intervention 1. And then at time 2, we again interview all of these individuals, and then the other part, the other half of the military, we intervene in time 2. And then at time 3, we have a follow-up test on everybody. So we have 200 in each of these groups. We have, in Lapu-Lapu, we have Mactan Air Force Base, and here we have Cavite Air Force Base in Cavite. And then in the police, we have Lapu-Lapu and Legazpi Daraga. In the high-risk population, we have 4 high-risk populations in Legazpi and in Lapu-Lapu. The work sites, we have 4 work sites. We have Del Monte Pineapple Corporation. We have the San Miguel Brewer Company in Lapu-Lapu. We have the Water and Power in Cagayan de Oro. And we have the General Milling Corporation in Mandaue City. Our transportation drivers are the jeepney are the taxi cab drivers and the pedicab drivers, or the tricycle drivers. It's two different populations. So the taxi driver will have the higher class, and the pedicab will have the lower class. So that was all. And then our social hygiene clinic is the control site. And here we're just looking at STIs over time, so that provides a base. These are some of the educational materials that the various risk groups developed. This is from the military. And then this is from the water and power. This one here, keep the lights on and be safe and alert against the STIs. These were all developed by our peer educators in our military program. And then the one with the, this is another one from the military, the strikers against HIV, AIDS, STDs. And then this is this is the General Milling Corporation. But it's a culture here. AIDS has a lifetime loneliness acquired from a short time happiness. You can see how that is very, very ingrained in the culture. So walking you through this type of intervention, let's see, where is it? It's not, oh, here, there. Okay, so these are baselines in terms of knowledge. It's very, very important to see how cognitive variables are very easily addressed, and they have almost an immediate impact in terms of change. So here you see the baseline from time one. It went from 19% to 22% to 45% at follow-up. So these are knowledge. It went 25 to 48, 30 to 34, 18, well, 16, I don't know why that. Policemen, 32, 52, and 61. Same thing with attitude source condoms. 14% to 21, 14 to 33, 18 there. But if you look at a behavior, and this is the behavior in terms of condom use behavior. You see from pre-test to post-test, this is our intervention group and our control group, 29, 26, and then 55. So very little change between pre-test and post-test. Why is that? Because it takes much more time to ingrain and develop the skills and the competencies and the communication skills for consistent condom use behavior, as opposed to knowledge and attitudes and beliefs. Those are cognitive changes that will occur readily. But behavior, because our condom use scale asks those 6 questions, and you have to answer correct on every high behavior use in order to scale rate high in terms of consistent condom use. This is our path analysis in terms of looking at condom use behavior. We see that behavioral intention certainly is very, very important in condom use. Condom attitudes are related directly to behavioral intention, and knowledge goes through attitudes, and education material does have a major effect in knowledge and attitudes and condom use behavior. Looking at the exogenous factors, the community and social supports, through our educational materials, such as the posters and flyers that are developed, also has a significant effect in attitudes and in behavioral intention. So these are some of our outcomes. Knowledge increased, no real change in knowledge. However, condom use attitudes were significant. Community source support wasn't significant, but behavioral intentions was also very important. Our R-squared, so 28% of the variability in terms of ever having sex with a CSW was predicted by these 5 variables here. If we look here in terms of changes over time, these are our logistic regression measures. We see that ever using a condom was significant in all of our intervention groups. So this is our conclusion, that the concepts of training peer educators in targeted communities has been well supported by various program managers. Education materials are being distributed and even shared with similar organizations in the community, including other factory workers. And so the diffusion of innovations in terms of this information dissemination process has encouraged other factory workers and other kinds of organizations to become actively involved. These are some of the pictures of our skill development with condom use behavior with a nurse and one of our peer educators here. Here's a class session in terms of our peer educators. These are demonstrations by the nurse from the social hygiene clinic. These are role-playing between our peer educators in terms, one is the female bar worker or their girlfriend, their girlfriend, and he's trying to convince his girlfriend maybe not to use a condom. And then they have reverse role plays. And so it's a very interactive approach. These are also peer counselors and role-playing. And these are the other important aspect that we were able to develop is the issue of a fotonovela. Fotonovela comes out of the soap opera of the Spanish culture. And fotonovelas are picture storybooks. And so part of our training program, when we trained our peer educators, these are male workers that are either in the military or taxi drivers that are being trained to counsel at least 10 individuals in their organization. So each organization, as you saw up there, has about 200 individuals. We worked with about 3,800 individuals in 18 different organizations. And so we trained these 2 individuals, and there were 20 individuals per organization. So they would cover all 200 individuals. And we shared with them the data at the aggregate level of their organization at baseline. We had them look at the frequencies, do bivariate analyses to look at relationship between variables, and then we challenged them to come up with solutions to the problems. Is it a problem of knowledge? Is it a problem of attitudes? Is it a problem of beliefs? And so they wrote these picture storybooks in each of these different photonovelas. So here you see, this is the Tagalog version and the English version of the military photonovela. And this talks about the problems that one recruit or one infantry personnel is talking to his officer about, I might have a problem with an STI, who do I see? And then he says, well, you go to your clinic nurse. And you can learn about condom use behaviors and be treated for HIV, for STIs. This is the social hygiene clinic. And so all of these are developed in terms of program materials, educational materials. This is a slide that I always use in terms of how do you disseminate your program. Well, one approach is at the individual level, and we know this theory by Prochaska called trans-theoretical level of change, but it's really called stages of change. So it's at the individual level, and the individual level of change is at, they call it pre-contemplation, that you've never heard about it, contemplation, preparation, in which you're starting to prepare in terms of maybe carrying condoms around with you. Action is that you're going to use condoms effectively, and relapse is when you actually go back, and maintenance is that you avoid the action, the relapse, and you continue to use it. The theoretical model, the trans-theoretical model, was really developed on smoking behavior. So have you ever heard about that smoking causes cancer or something like that? Or have you ever thought about not smoking as pre-contemplation? Contemplation might be, have you talked to anybody about it? Maybe if you talk to your healthcare provider, that might have been the impetus to begin to plan it at the individual level. But we, working in communities, we're looking at Everett Rogers, the fusion of innovation model, in which you look at the curves here in terms of adoption. And so that's called the fusion of innovation or adoption behavior. And so you first is awareness through the mass media. And the first group of individuals that identify awareness and they go through this stage of adoption are called the innovators. These are individuals that are very different than the other members in their community. They read the newspaper. It's not that they're higher educated, but we see that they are really in tune with things in the community in terms of innovations that might, they take a risk in terms of using that. The very first innovation that Rogers identified was during the Green Revolution in Asia. And they're looking at the rice crops, looking at agriculture. First, there were hybrids of the rice strain, and so they could grow a hybrid that had 4 harvest seasons instead of the usual maybe 1 or 2 seasons. So they could get double the number of the quantity, and the amount in each of the crops was almost double as well. But not everybody accepted that. Some were what we call late adopters or the laggards. And it takes the high adopter or the early adopter or the innovator, it takes them to maybe provide the social persuasion or the reinforcement based on trust and confidence and acceptability of this particular individual that comes from my community. And so the take-home message when you're dealing with a community is you're not going to be constantly trying to work on the awareness or the interest. It will be very, very high already. Put your resources in getting these individuals that have already adopted to begin to diffuse that adoption and address the psychosocial and behavioral determinants in terms of the barriers that these people are resistant to, that provide that resistance. Okay, thank you all very much for your patience. And
we have time for 2 questions.
There is so much to share, but I want to make sure to take this opportunity and appreciate again Department Chairperson, Professor Untitled, and Professor Moreski to take the time from their very, very busy schedule to make this happen, all to the benefits of our students and our colleagues here. If there's any questions quickly that we can answer, for those of you who must leave, I understand, I would imagine there is possibility for communication online. But as you notice, there is so much to share. Is there any question?
I have one. I was trying to read in the structural equation model.
yes,
I was trying to read the values, but it
Right.
seemed to me the managers had the most powerful influence on the outcome.
yes,
Accurate.
right,
But there was also a very strong line from that was more focused on the individuals and their level of knowledge.
okay, maybe I can go back there so that everybody can.
Sure.
Yes.
Okay, so,
AIDS, yeah. Oh, I see. It's AIDS knowledge did not. It's 0.35. I was
Right.
looking at this. Yeah, they are negative. I didn't.
and see if managers have perceived knowledge, if they have very high perceived knowledge, they're less likely to have negative attitudes, yeah.
And the AIDS knowledge at the bottom.
AIDS knowledge is
very
positive,
high.
yes, directly, and then also negative.
And what's the hanging 0.70?
That's the unexplained variability. And so 30% of negative attitudes towards condoms is, and condom use efficacy is explained by negative attitudes towards condoms. And so this is also, in our model, a total of 56% of condom use and efficacy is explained by this constellation of independent and interaction effects, yeah. Yeah, this is a model that has been developed by Dr. Bentler, Peter Bentler at UCLA. And Dr. Bentler is a very, very famous professor in terms of structural equation modeling. And he has written his own program in C+. And he teaches workshops in the summer. And he provides all of the students in his workshop his software to actually go through. And several of our students in our doctoral program are strongly encouraged to take his courses, as well as courses in education and also psychology. But those are 2 other departments that students really gain a utility of using high-powered statistics, as opposed to just our own biostatistics in our school.
Well, we will continue at lunch. Thank you so much.
Okay, thank you all.
We will token of our appreciation from our
Oh,
students
thank you very
and
much, Debbie.
faculty. So please
Wow,
join me
thank you.
to